Uh, may I request Dr. Gaurav to kindly go on? Any quick question for Dr. Ramamurthy? Well, I think he showed various situations of PCR and how beautifully he can handle it. We'll go on to Dr. Gaurav Luthra, who will be talking about, as you all know, he's from Dehradun, a very astute surgeon, and really a fantastic personality, I would say, a nice human being. He'll be talking about pupil and iris issues, expanders, and reconstruction, Gaurav. Maybe if we could stick to the time, because we are...
Thank you so much, Dr. Mahipal, for inviting me. It's a pleasure to be on your course. I will try to show a few situations requiring pupil and iris repairs. And this was a 22-year-old man with trauma to the right eye, and initially had presented to our emergency with an iris prolapse, and was treated by one of our emergency surgeons and had to undergo an iris abscission and repair. And after that whole process was over, patient was further managed and later on presented with a cataract that was a month or two later, and now we had to deal with the cataract, but the situation also required something to be done about the big iris defect which was left behind. So this is how it looked, and this was a large size repair which was required. I initially thought that I might get away by doing a pupilloplasty by a single pass 4-throw kind of a thing, but I had to bridge this big defect, and then I had to bridge this defect. So because of the loss of iris tissue, it was looking very unlikely that we'll be able to form a pupil of an adequate size, and there wasn't enough tissue to do the repair, so we had to think of something else. And also patient had significant astigmatism, as you can see, so we thought that we might be able to use, and it was a symmetric astigmatism, we thought we'll use a toric lens. We tried to decide upon several designs of these iris prosthetic devices that we could use. We thought of using a 120 degrees, but we realized that that may not be able to cover the defect, so we customized and formed a 180 degrees iris prosthetic implant over there, and went ahead with the cataract surgery, which was mostly a routine cataract surgery with no major challenges there. And once the cataract was out, that was it was a soft cataract, so not much to do there. And once that was gone, we could implant the toric lens. And now we had the task of placing the ring there. So the challenge was whether to put it into the bag or put it into the sulcus. And as you can see that the size of the implant is very, very big. Getting it into the bag is very, very unlikely. In fact, we had to enlarge the incision to almost from 2.2 to almost 2.8 millimeters to accommodate that thing, because as it rotates, it requires a bigger and bigger incision. So eventually we were able to get it into the sulcus and position it correctly to correct that defect, and it was overlapping the edge of the optic. And once the pupil was constricted, the patient actually did well, and the toric IOL placement looked out pretty good. There was almost 3 diopters of astigmatism which was corrected, and the eye trace showed that the astigmatism was almost fully corrected over there. And that was the end of the case, and patient did extremely well. Now, this was another situation where a patient had a multifocal implant in one eye, and in the fellow eye he presented for cataract surgery with a very peaked kind of a pupil towards one side, and frankly the visual axis was getting covered by the undilated pupil. So we had to think of doing something where if we had to, and patient was very keen to get a multifocal implant in the other eye as well, because the first eye was doing extremely well. As we went ahead, now this is a dilated pupil, so obviously it looks different, but in the undilated state the pupil was totally drawn to the side of the corneal opacity from previous some kind of a trauma over there. And went ahead with the cataract surgery. Again, nothing much about the cataract surgery, except that we had a situation where the rhexis was trying to run away. So I used this Y-tip manipulator to create space and retrieve the rhexis using the Bryan-Little's maneuver. So I'm moving away the pupil with my Y-tipped manipulator, and then doing a gentle Bryan-Little's maneuver there to retrieve the rhexis, as you can see over there, and I'm able to get it back. there it comes back, and then I can complete the rhexis. So I'm basically getting some visualization and then retrieving that rhexis. So this was an additional little bit of a challenge which developed during the surgery. And once the cataract was gone, I had a regular rhexis, complete rhexis. So after that, the implantation of a toric multifocal implant here. So once that is in position, now the job of making the pupil. So I'm doing a sphincterotomy there because that's the place where exactly the pupil was getting drawn. So the idea is to ensure that we have just the right size pupil at the end of this surgery. So once I've done that, I will put pilocarpine and see whether I'm getting a well-centered lens and whether the lens is now the visual axis is exposed to the thing. And now because on the other side there was a situation with the pupil being peaked, so I'm going to make that side pupil smaller so that the optic edge is not exposed, causing more glare and situations for the patient. So doing the single pass 4-throw pupilloplasty, I'm going to pass a suture, and that will help me make the pupil a little more central. So the whole idea is to have a more centralized pupil by various methods, and patient eventually did quite well and had a good outcome. So this is how it looked in the post-operative period. It's not beautiful, but functionally it was pretty good, and the patient was fairly satisfied, and there was high astigmatism which we corrected as well along with the multifocal implant. And my last case, where I'll try to show you an iridodialysis repair. This was again a firecracker injury, and we had a big iridodialysis for this lady, and eventually she developed a cataract. And when we, again now here I'm supporting the pupil with iris hooks because it's a big dialysis and I need that area to be clear. And there is a little bit of subluxation in one area, so we'll have to put in a CTR as well along with the iris repair. So go ahead with the cataract surgery, do the rhexis, and now once the rhexis is through, you can go ahead, complete the cataract surgery. And once that is done, I'm putting in a capsular tension ring to support the bag and getting the cortex out. And then the IOL goes in, and now this part is taken care of mostly. Now the job of correcting this iridodialysis, and as I started off, I'm tightening the chamber because I'm going to use Hoffman pockets. There was a pterygium surgery done over here, so there is scarring, so I don't have space to make a good conjunctival flap. So I'll have to go onto the Hoffman's pockets, and this is the first one. Now this place I made a mistake. Now just see what I'm doing. I've gone in, I've not supported the iris with a counter pressure of some kind, either with a forceps or something else, and I created a bleed and a little bit of extension of the iridodialysis. Now this is a learning point because this was a gross mistake which I made just because I was concentrating more on the Hoffman's pocket, and as I passed the suture there, but now I'll have to kind of get this back somehow. I did manage to pass the suture, but created a big hyphema there, and the iris of course maybe tore a little bit more from the root, and you can see that because of the shallowing of the chamber, the iris from the other side has started coming out. Reposit that. The other learning point here was that I shouldn't have removed my iris hooks. I should have let them be because they would have supported the iris there and not allowed this to happen. So the iris hooks can be removed as needed at the time of passing the suture rather than at the time when I started the surgery itself. So I'm putting the iris hook back, and now I've learned my lesson, so I'm doing a railroad technique. I'll finish in 30 seconds. I'll pass. What I'm doing is now I'm using counter pressure. So as I'm passing the 10-0 Prolene straight noodle here, I'm using the 26 gauge, and with counter pressure, I'm also kind of passing it so that I'm getting the suture passed at the exact point, and there is no pull on the iris now. So that done. Now the first suture is done, and I'm going to bury the knots inside the Hoffman's pocket, create a second pocket there, just like we did for the first one. And this is right adjoining the site where the pterygium surgery had initially been done for this patient, and I'm avoiding that area. It's a little vascular, so it's tending to bleed, but essentially the same way. But this is also the nasal part of the eye, the nasal side, so you can see that I'm having to bend my 10-0 needle because if I keep it straight, it won't be able to negotiate over there. There's little space. And once I'm done, then all the 3 Hoffman's pockets done, I'll take you to the end of this surgery, and We'll go on to the next presenter. This is the third Hoffman's pocket. Again, I am passing sutures through that. It's a very elegant way because the Hoffman's pocket, they don't disturb the conjunctiva. Future trabeculectomies or other glaucoma surgeries can be done, and also is much less invasive and post-operatively looks very clean even from day one. And at the end, you have a good iridodialysis repair, and the pupil looks nice. And this is the post-op picture. Patient did well, was almost plano in this eye and much better vision than the fellow eye, which was phakic with a plus 1.5 sphere. So thank you so much, and with that I'll finish.
Thank you very much, Gaurav, for an excellent presentation to show what all things are. The only problem of the analytic segments and all that he has shown is that unfortunately they have all come under devices, and what we used to have earlier, I have no financial interest, but the best kind of things were supplied by Morcher out of Germany. So they have not been registered as a medical device in India, so they don't even send them and you can't use them. That's the only problem. And you are using the one made by, I think, Care Group. I would still have my apprehensions of the pigment leaching in these cases, because there is a special treatment that you do where the pigment is strongly embedded into the material, and that makes the whole thing brittle. So and they are large and they are brittle, they can tend to break. So that is the only problem which is there. So as of today, we have no other option except for that one particular thing to use.
You're absolutely right, and I keep obviously hearing this, but I've been using maybe 15 years now their aniridia rings and some of these segments. Thankfully, I've not really seen
I'll
that
show you
happen, but
pictures.
I've heard many surgeons mention that they have encountered it, so one has to be very careful anyway.
I don't know anybody in the audience would like to say, but yes, they don't remain black, or the pigment tends to leach out, and that causes a secondary glaucoma and inflammatory response in the cases. So it's, I think, a special technique that is there so that the pigment stays constant.